So, assalamu alaikum. I think our focus here is on a very important one, that's cardiovascular disease management of diabetics in Ramadan. Sorry. So obviously this is a group that's quite familiar with Ramadan. I think the main issue is that the timing in Ramadan can sometimes change, usually shorter in the winter months, but up to 20 hours in the summer, of course, depending if you're living in the northern or southern hemisphere. So the longer duration between suhoor and the break of fast can have an impact on dehydration and hypoglycemia risk. So fasting is not just specific to Muslims. Orthodox Christians also fast during Lent from certain foods, although not from liquids. Many other religions, such as Baha'is, Hindus, and Jains, also fast for different extended durations. So the key point, though, is the burden of fasting is very large. There are about 150 million Muslims with diabetes, and about 80% of type 2 diabetes patients actually do fast during Ramadan. So it's a very important clinical question. Now, in healthy individuals, fasting has a specific physiological response, and that is the generation of ketones, which transfers energy into liver, muscle, and adipose tissue. Increased glucagon will lead to glucogenolysis and gluconeogenesis, with glucogen stores coming down. In diabetics, because of the specific metabolic abnormality, hyperglycemia often results due to excessive gluconeogenesis and glycogenolysis, but also because of the insulin resistance, there may be ketogenesis and ketoacidosis as well. Now, fasting is not applicable to all adult Muslims if it is detrimental. The Quran states that fasting should be avoided, and the Prophet Muhammad, peace be upon him, actually states that it is Allah likes the permissions to be fulfilled as the will to be executed. So taking what is known as rukhsa is very important, and many patients will ask about this. So any fasting that exposes patients to health hazards is not in accordance with Islamic jurisprudence. So this is where the recommendation of the pre-Ramadan 1-month checkup, which should be done now since April has been the month of Ramadan, and in patients with cardiovascular disease and renal disease. And finally, the decision to fast or not to fast is left at the discretion of the treating physician after the review of the patient. Now, stable coronary heart disease is very important. There is a high burden of atherosclerosis in our region, and patients with stable CAD can fast. Oftentimes, the major adverse cardiac events are not significantly reduced. However, it is specific that patients with unstable disease or recent and pending revascularization should refrain. Now, it has been noted in clinical studies that acute MI is not increased during Ramadan, and there was also no increase in hospitalization with heart failure from many studies that I will discuss shortly. And in fact, most cardiac medications can often be prescribed once or twice a day to coincide with suhoor and iftar. So multiple studies have suggested that Ramadan fasting is safe in stable coronary artery disease. In fact, during Ramadan fasting, the pro-inflammatory markers were significantly reduced up to 4 weeks after Ramadan, denoting a potential long-term beneficial of Ramadan fast on the inflammatory markers. And most of the studies actually followed the patients 4 to 12 weeks after Ramadan fast. And this is the recent reference. So just to help highlight this issue, he's a 60-year-old male with type 2 diabetes and ASCVD. He's educated, he's a businessman, family history of dyslipidemia and diabetes. Is type 2 diabetes and dyslipidemia since 2014, so now about 8 years, and hypertension since 2017. So his coronary heart disease stable and had a percutaneous intervention done 4 months ago. His medications include empagliflozin, metformin, atorvastatin, perindopril, amlodipine, and aspirin. So in terms of symptoms, he only has mild nocturia. His BMI is 30. His blood pressure is controlled, and non-proliferative diabetic retinopathy is his other complication. So his fasting glucose 118, A1C of 7.1, LDL is well controlled, and his GFR is 69, ACR is 42. So the stage of CKD also is very early. So what helps inform us a lot is this extremely detailed and very efficient IDF DAR risk score that was obviously developed by the group, a lot of input from Professor Hassanein. So I've tried to summarize this patient in the blue arrows. So He's type 2 diabetic, so he's a 0, duration less than 10 years old of diabetes, no hypoglycemia, reasonably well controlled glycemic control. He's not on insulin or sulfonylurea. He is self-monitoring. He has never had DKA. He has stable vascular disease. His GFR is above 60, obviously not pregnant, not frail, doesn't do physical labor. He's actually a businessman, no negative Ramadan experience, and the fasting expected in our area will be less than 16 hours. This gives him a score of 2, which means with a low score, he's low risk and can be fasting. So this is a structured way of actually helping the patients go through this checklist. It's a little bit lengthy, but I think worthwhile in terms of advising the patient. Now, what about cardiac risk factors during Ramadan? So weight loss actually can occur during Ramadan, and if maintained long-term, can be beneficial, especially if the patient has metabolic syndrome. And this is where patients who do fast also the nawafil during the non-Ramadan month. So some of the patients, as you know, fast a couple of days a week. Also, it helps in terms of smoking. Now, in terms of risk factor improvement, this has been well studied. Improvement of the 10-year CAD risk score based on Ramadan, after Ramadan fasting, significant HDL increase and low LDL, blood pressure and body weight after Ramadan. And these are typically beneficial for cardiovascular risk. Very interestingly was this paper, which showed endothelial dysfunction, which is a major loss of nitric oxide bioavailability as a cause of cardiovascular disease. This small study from Yousefi's group showed that nitric oxide levels were significantly higher in Ramadan compared to the baseline value. Smoking is very interesting. So in the region, many public health authorities use Ramadan to encourage people to smoking cessation. And smokers are motivated by the fact that if they can abstain during the fasting time, they can also abstain later as well. So it's almost like a trial period. And enforced abstinence during the daylight helps people withdraw in regular smokers. With sustained abstinence over the month, it becomes easier and easier over time, unless they become totally abstinent. So I think one of the points is that this is evidence that smoking cessation programs initiated during Ramadan with this additional religious timing feature should be a measure to help people control smoking long term. Lipids do improve during Ramadan. Several studies showed the reduction of total cholesterol and LDL and triglycerides and significant increase in HDL. And this is a progressive and significant increase, which was seen even after Ramadan as well. Now, weight is a little controversial. Most studies show some weight loss. Almost all the studies show it's not persistent. And in fact, weight regain is seen after Ramadan. So I think we have to emphasize the fact that overall the prescription should help to extend beyond Ramadan as well. Now, one interesting piece of information that should be discussed with patients is that large meals at suhoor and iftar may lead to glucose spikes, and these large nighttime meals after long periods of fasting can actually increase the risk of adverse events, including hypoglycemia and hyperglycemia. However, increasing satiety with GLP-1 receptor therapy actually can help reduce the feasting while breaking fast in some patients with type 2 diabetes in Ramadan. This has been the subject of a couple of clinical studies as well. Now, most importantly, do acute cardiac events increase during Ramadan? And many clinical studies have shown that Ramadan fasting has actually decreased admission for acute coronary syndrome, acute MI, and unstable angina. So it does not increase the acute cardiac illness. And in fact, ACS, heart failure, AFib, and stroke is similar compared to other non-fasted months. This group from Iran looked at coronary artery disease, cardiac events on 1,600 patients in their hospital over about 7-year period. The number of ACS was significantly lower in Ramadan than before or after. So it does not increase ACS events. This is one of the largest studies from Qatar, the Hamad Medical Corporation, Suwaidi et al. Over 10 years, 20,000 patients were admitted, 8,400 were Qataris, all of whom were basically fasting, and there was no difference in acute MI before, after, during Ramadan. So no increase specifically. And this Turkish study, again, for emergency room visits for ACS did not change during the Ramadan period. This is a very interesting paper that actually looked at Ramadan fasting after percutaneous intervention. And their summary is low-risk patients with a normal ejection fraction who underwent a PCI may fast during Ramadan. At the same time, if a patient has had a recent acute coronary syndrome and has a PCI for an acute MI, non-STEMI or STEMI, within the first 3 months should not fast. So after the 3-month period, we should be okay. And if you remember with this patient, it's been 4 months and he had a stable angina and not an acute coronary syndrome. Congestive heart failure is very important. Fasting does not increase hospitalization during for congestive heart failure. Again, in the Qatari registry, 2,100 Qatari patients with heart failure, no significant difference before or after Ramadan, no changes in the function class or any biological or biochemical profile. However, it's very clear that patients with decompensated heart failure or patients on large doses, especially of loop diuretics, should not fast, especially in the warm months when Ramadan falls during the summer. So this is about medication adjustment and diuretics in particular. And this is a more recent study from the Saudi group here looking at Ramadan fasting in chronic heart failure. And you'll be interested to see something very interesting here. During Ramadan fasting, the number of patients whose functional class improved from 3 to 2 to 1 actually increased to almost 60%, which means that with the appropriate education, heart failure can actually be modified. As you know, heart failure is largely driven by volume excess. So in congestive heart failure, there are some caveats as well. May not be extrapolated. They did not include patients with advanced functional class or unstable patients. Those we've already identified in heart failure are not supposed to fast. And most of these studies were Middle East or Gulf, so patients in the northern climes where the duration of fasting can be up to 20 hours like in Sweden may not be applicable. Medications, especially cardiac medications, I think 3 times a day medications should be changed to sustained release medications. Dehydration, electrolyte imbalance is very important, especially in patients on large doses of diuretics, and in particular, antihypertensives that contain large doses of diuretics and diuretic dosings for heart failure and hypertensives should be adjusted down by about 50%, especially in prolonged fasting. And many of the cardiac medications are now once a day dosing. Warfarin actually is important because we have a lot of patients who have AFib or VTE. Ramadan fasting does not influence efficacy or safety of oral anticoagulation. This is a 5-year study where they looked at patients who fasted and did not fast. Thromboembolic events occurred in a very small number of patients in the fasting and non-fasting groups, and there was no adverse effect on efficacy or safety or anticoagulation, no statistical difference. So to summarize, who should not fast? This is a fairly small group of patients with cardiac conditions should be advised to refrain. These are patients with acute cardiac illness, acute MI, and acute coronary syndrome. Uncontrolled hypertension on multiple doses during the daytime should be counseled against fasting. Severe heart failure requiring high doses of diuretics should refrain from fasting. And finally, Ramadan is an ideal platform to target year-long lifestyle modification to ensure that whatever healthcare benefits have been gained during this month are perpetuated.